Welcome back, everyone. The second last element of this topic that we're going to talk about is Haart, or highly active antiretroviral therapy, which is used to treat HIV infection. Okay, so Haart is highly active antiretroviral therapy, and again, it is used for HIV infection. When people are HIV positive, they are given two main classes of antiviral drugs that inhibit the viral enzymes, and these drugs are used in combination. Now, if you were paying attention in the HIV pathophysiology recording, you would have seen me point out the different sort of enzymes that are inhibited with drug therapy. So they are reverse transcriptase, integrase, and protease. Okay, so normally speaking, people are given a combination of 3 drugs, but sometimes 4, but usually triple combination therapy, and they're given 2 reverse transcriptase inhibitors and either 1 integrase inhibitor or 1 protease inhibitor. And by using all of these drugs in combination, what that does is it inhibits HIV replication. It also reduces the plasma RNA level to undetectable levels. So it's below the level of detection of the assays or the tests or the kits that are used to measure HIV viral load. And patient survival is prolonged, and it's prolonged, to such an extent that people are not actually developing AIDS anymore in the developed world anyway. Now, lifelong treatment does make compliance difficult, and it does come with many unwanted effects. So people have to take this triple combination therapy every day, different dosage regimens. And one of the most unwanted effects is a condition called lipodystrophy, and that's due to this drug therapy, right? And lipodystrophy describes sort of a redistribution of adipose tissue or fat tissue, and particularly around the abdomen. And that causes these metabolic and cardiovascular complications. Now, with Haart, the virus is not completely cleared, but it remains latent. So remaining latent, say, in lymph nodes, for example. Okay, so with Haart, some of the highly active antiretroviral therapy drugs have poor penetration into the central nervous system. And I think I did mention this, that, this was why that AIDS dementia complex 20 to 30 years ago was such a huge issue, because these drugs we didn't have any drugs to begin with, right? And then the drugs that were developed couldn't penetrate into the central nervous system. However, many of them do now. There's also difficulties prescribing drugs to pregnant and breastfeeding mothers, clearly because, the crossing over of drugs to the fetus or the baby. More recent therapies, though, do include CCR5 and CXCR4 inhibitors. Again, if you were listening in a previous recording, you would have heard me talk about how CD4 is the main receptor for attachment of HIV, but there's also a co-receptor that's needed for entry into susceptible cells. And on macrophages, that co-receptor is a receptor called CCR5, and on T cells, it's CXCR4. Okay, so inhibitors, if you can block those receptors, you could therefore theoretically block entry of HIV into cells. Now, really interestingly, CCR5, so the genes that code for this CCR5 receptor, I know that I'm a wild type, so my 2 alleles for those genes are wild type. So if I were to become infected with HIV, and if I wasn't being treated with Haart, my course of infection would probably follow the normal one that I sort of explained in that previous recording of, HIV positive and then out to about 10 years and then developing AIDS. However, people that are heterozygous, so meaning that they have one wild type gene and then sort of one mutant gene for CCR5, seem to have sort of a much longer progression to AIDS from when they're infected. And there has been, a population of women actually in Africa who had both mutant alleles for this CCR5, and it was shown that they couldn't be infected at all with HIV. So that's just a little bit of an aside. Neutralizing antibodies and other antibody therapy that targets virus to allow cytotoxic T cells to kill infected cells also shows promise. So vaccination does remain the ultimate goal with HIV infection, but it does remain problematic. And this is due to those sort of constant point mutations that accumulate in the HIV genome, leading to antigenic drift. Okay, so the problem with that is, let's say you've designed a vaccine to save the GP120 spike protein in HIV, but if you're getting, an accumulation of mutations that code for that spike protein, eventually that spike protein would be a little bit different, and the vaccination actually wouldn't work against that sort of new variant of HIV. I'm sure some of you have heard of PrEP as well, which is given to people who are at high risk of becoming HIV positive. So this is another sort of combination of the drugs that I was describing on the previous slide that sort of build up in the bloodstream and prevent infection. PrEP itself stands for pre-exposure prophylaxis, and it has been showing really good results in general. Okay, everybody, that's it for me.